Hello everyone, my name is Magdy Abdel-hamid, Professor of Cardiovascular Medicine at Cairo University. It's my pleasure to give this presentation in the review course organized by the Egyptian Society of Cardiology. And my assignment today is revascularization in chronic coronary syndrome from courage to ischemia. This is a very important topic, especially after the release of new ESC guidelines for chronic coronary syndromes and after the presentation of the new trial, which is an ischemia trial, the trial which might change the practice for patients with chronic coronary syndromes. So from this slide, we know that patients with chronic stable angina have an atherosclerotic plaque which is characterized by no excess lipid pool, fibrosis, calcification, even in the presence of severe obstruction. This is not a vulnerable plaque. So those patients are complaining of exertional angina and the positive exercise tolerance test or evidence of ischemia by myocardial perfusion imaging. So the strategy of treatment of those patients, in addition to anti-anginal treatment, revascularization in high-risk patients. On the other hand, the patients who have vulnerable plaque, those patients, even in the presence of minor obstruction, the plaque is characterized by thin fibrous cap and the excess lipid pool, excess inflammatory infiltrates. So these plaques are liable for rupture, causing an acute coronary syndrome, acute myocardial infarction, unstable angina, non-STEMI, and even sudden death. So the management of treatment of those patients, pharmacologic stabilization by antithrombotic treatments, lipid-lowering therapy, and the early identification of high-risk patients for revascularization, primary PCI for patients presenting with STEMI. Patients who have chronic coronary syndrome, the aim of treatment is to relieve symptoms, which is mainly angina, in addition to improve prognosis. So the new ESC guidelines 2019 presented the pathway of management of those patients who have angina and or dyspnea and coronary artery disease. So in the presence of anginal symptoms, they recommended that to prove the presence or absence of myocardial ischemia. In the presence of documented ischemia and the presence of multivessel disease, you have to identify lesions which are physiologically significant, FFR less than 0.8 or an IFR less than 0.89. So consider revascularization on top of medical therapy. If there is no evidence of ischemia and diameter stenosis more than 90% or FFR, IFR the same cutoff levels that are mentioned now and ejection fraction less than 35% due to coronary artery disease, also revascularization is recommended. Patients who have no angina but documented ischemia with a large area of reversible ischemia, more than 10% of the LV myocardium, revascularization also is considered on top of medical treatment, and the absence of ischemia, the same recommendations, significant stenotic lesions of coronary arteries and significant narrowing detected by physiological lesion assessment in the cath lab. This is an interesting study, an observational study included more than 10,000 patients who have evidence of myocardial ischemia by myocardial perfusion imaging. And in this study, they proved that revascularization was associated with lower risk of cardiac death only in patients who have ischemia more than 10% on myocardial perfusion imaging. So in comparison to medical treatment, revascularization was associated with lower incidence of mortality. We have the landmark trials comparing medical therapy in comparison to revascularization. So starting from COURAGE trial, BARI 2D trial, and the FAME2 trial. So look for COURAGE trial, which included 2,287 patients who have a stable ischemic heart disease, who were subjected to PCI with optimal medical treatment, or optimal medical treatment alone, looking for the primary endpoints, which was death or myocardial infarction. So in COURAGE trial, PCI did not reduce death or myocardial infarction in stable ischemic heart disease patients compared with optimal medical treatment. Another study, which is a BARI-2D trial in diabetic patients, a study which included 2,368 patients with type 2 diabetes and stable ischemic heart disease, and the same patients underwent revascularization, either CABG or PCI, and optimal medical treatment compared with optimal medical treatment alone, looking for a primary endpoint which was all-cause death. And again, revascularization in BARI-2D trial did not improve survival in diabetic patients with stable ischemic heart disease. If we look for another study, which is FEM2 trial, in FEM2 trial, which included 800 patients scheduled for 1, 2, or 3 vessel drug-eluting stent PCI, randomized to FFR-guided PCI, plus optimal medical treatment compared with medical treatment alone. And the primary endpoint, death, myocardial infarction, or urgent revascularization. This study, which was published in the New England Journal of Medicine 2012, looking for the primary endpoint. Compared with medical treatment, FFR-guided PCI was associated with better outcome in terms of all-cause death, myocardial infarction, or urgent revascularization, which was the primary outcome. This is an interesting meta-analysis for PCI versus medical therapy alone in patients with a stable obstructive coronary artery disease and myocardial ischemia. And the inclusion criteria of this meta-analysis included patients who were used statins in more than 50% in both groups, and more than 50% stent use for patients with stable ischemic heart disease. They looked for the outcome in terms of death, myocardial infarction, unplanned revascularization, and angina. And interestingly, they did not find statistically significant difference comparing optimal medical treatment alone or PCI. So in this study, PCI did not reduce mortality and did not reduce myocardial infarction. However, unplanned revascularization and angina improved in FEM2 trial and COURAGE compared with medical treatment alone. So, according to the results of these important trials comparing optimal medical treatment with revascularization in patients with a stable ischemic heart disease. However, we have limitations of these trials. Number one, selection bias, randomization for those patients occurred after doing catheterization. Number two, no minimum threshold for ischemia required. Number three, drug-eluting stents not used in COURAGE and BARI-2D trial. And PCI not FFR guided in the same trials, COURAGE and BARI-2D trial, and bypass surgery not done in COURAGE and FEM2 trial. So we have many limitations for these trials which may have an impact on the outcome of these trials. So the remaining gap in patients who have chronic coronary syndrome. Is there any high-risk group of stable ischemic heart disease patients other than left main in whom a strategy of routine revascularization improves outcome in the era of modern medical therapy? This is a very important question. So if the clinical trials in the optimal medical treatment era show no clear death or myocardial infarction benefit from an initial strategy of revascularization, do we need to do coronary angiography for all patients with stable ischemic heart disease prior to a trial of optimal medical treatment? This is a question which have been answered in the landmark trial which have been presented in the last meeting of American Heart Association, the ISCHEMIA trial. What you should know about this practice-changing trial? ISCHEMIA trial is an international study of comparative health effectiveness with medical and invasive approach. So look for this trial. The important question which was raised for ischemia trial, in stable patients with at least moderate ischemia on an imaging stress test, is there a benefit to add cardiac catheterization and, if feasible, revascularization to optimal medical therapy? This is the rationale. This is the question which was suggested by this landmark trial. So look for the overview of ischemia design. Ischemia design, patients who have moderate or severe ischemia documented by exercise test or imaging study, and then sent for the coronary calcium scoring as well as CT coronary angiography, which was performed in 73% of randomized patients. Then patients were randomized, either conservative strategy or invasive approach, and look for the outcome to compare the outcome for patients who have chronic coronary syndrome when treated with medical treatment or treated with revascularization. Study design again, CT angiography not required in patients with estimated GFR less than 30. Those stable patients who have moderate or severe ischemia determined by site, and then blinded CT angiography, core lab interpretation for the CT angiography and evidence of ischemia, screen failure excluded from the trial. Other patients were randomized to invasive strategy, which is an optimal medical treatment plus angiography and optimal revascularization, or conservative strategy alone, just optimal medical treatment alone, and catheterization was done only for patients who have unresponsive to optimal medical treatment. What are the endpoints in the ischemia trial? The primary endpoint was a composite of cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And the major secondary endpoints: time to cardiovascular death or myocardial infarction, quality of life. Other endpoints included all-cause mortality, net clinical benefit by adding stroke to the 5 components of the primary endpoint or components of the primary endpoint. Statistical considerations: the study was powerful enough according to this detailed statistical analysis. So what are the inclusion criteria for patients who were randomized to conservative versus invasive strategy in ischemia trial? Age above 21 years, moderate or severe ischemia, detected by nuclear perfusion imaging, 10% or more of LV ischemia, the vitamin stress echo the presence of 3 or more segments, stress-induced the moderate or severe hypokinesis or akinesis, and CMR if they have by perfusion 12 segments or more myocardial ischemia, wall motion abnormalities 3 segments out of 16 with a stress-induced severe hypokinesis or akinesis. Stress test which was performed only in 25% of patients. Positive exercise test, 1 millimeter or more S segment depression in 2 leads or more than 2 millimeter S segment depression in a single lead at less than 7 minutes with development of angina. Major exclusion criteria in ischemia trial included the patients who have NIHA function class 3 to 4 heart failure, unacceptable angina despite medical therapy, ejection fraction less than 35%, acute coronary syndrome within 2 months, PCI or CAPG within 1 year, estimated GFR less than 30 milli, those patients subjected to another study which is ischemia CKD. CT angiography eligibility criteria included 50% or more stenosis in a major epicardial vessel in patients who have stress imaging positive, 70% or more stenosis in a proximal or mid vessel for patients who have positive exercise tolerance test. The major exclusion criteria: patients who have left main disease 50% or more. The endpoints definition for the study: cardiovascular death, myocardial infarction, unstable angina, heart failure, or resuscitated cardiac arrest. Myocardial infarction, universal definition of MI, was used in this study, but it's important for the definition of spontaneous MI. type 1, 2, 4B, or 4C, for peri-procedure myocardial infarction, either after bypass surgery or after PCI. So procedure MI definitions in ischemia trial, this is very important because in PCI-related MI, which is type 4A, according to the universal definition of myocardial infarction, according to the estimated CKMB level, it is 5 or more upper limit of normal, troponin more than 35 upper limit of normal when CKMB is unavailable, plus at least one of the following: new ECG changes, ST segment elevation or depression, new pathological Q waves in 2 leads or more, new persistent left bundle branch block. Angiography, reduce the flow in a major coronary artery, type C or greater dissection. And if we don't have this criteria, the definition for peri-procedure MI was defined as CKMB more than 10-fold upper limit of normal or troponin more than 70-fold upper limit of normal. After bypass surgery, post-CABG related MI type 5 was defined as CKMB, which is preferred over troponin more than 10 times upper limit of normal, troponin more than 70 times upper limit of normal, plus at least one of the following: imaging criteria positive, new ECG change such as new pathological Q waves or left bundle branch block. If it is not available, CKMB above 15-fold or troponin more than 100-fold. So these are the criteria used in ischemia trial to define peri-procedure myocardial infarction. Again, the endpoints definition: unstable angina defined as prolonged ischemic symptoms at rest or accelerating pattern resulting in hospitalization, heart failure function class 3 to 4 need hospitalization and intensification of treatment, resuscitated cardiac arrest, successful resuscitation, out of hospital, discharged from the hospital alive. So look for the study flow of ischemia trial. Enrollment was excellent. 8,500 patients were enrolled in this study. However, screen failure was common due to insufficient ischemia, no significant obstructive coronary artery disease, unprotected left main in 400 patients. So the randomization included only 5,179 patients and CT angiography performed in 73% of patients. Look for patients who were randomized to the invasive strategy, 2,500 patients, and the mean follow-up was 3.3 years, and 99% completed the follow-up. This is very important in a landmark trial. The randomization to conservative strategy included 2,500 patients and the same follow-up and the same percentage of patients who were followed up after the study, more than 90%. So look for the baseline characteristics of patients included in ischemia trial. This is very important because diabetes well represented in 42%, ejection fraction, the median ejection fraction was 60%, history of angina 90%, and stress imaging in 75% and stress test only in 25%. If we look for the core lab interpretation for the degree of ischemia, severe ischemia was identified in around more than 50%, 53% invasive strategy and 55% in the conservative strategy. Moderate ischemia, 34 versus 32%, mild ischemia only in 12%. And look for the number of coronary vessels by CT angiography for a significant coronary artery disease, more than 50%. And we can see that we have 3-vessel disease in around 47% in patients randomized to the invasive strategy and 44% in patients randomized to the conservative strategy. If we look for specific vessels with more than 50%, we can see that LED is well represented in those patients, 87%, as well as proximal LED, 47%, circumflex 68%, and right coronary artery 70%. The risk factor management is very important for patients who will be given optimal medical treatment in both strategies. So if we look for the use of statins before and during the last visit, we can see the average. For statin, 95%. For other strategies of treatment, we can see that the use of ACE inhibitor also 66 and 70%. And the criteria of optimal medical treatment should include LDL level less than 70 milligram per deciliter, systolic blood pressure less than 140 millimeter mercury, the use of aspirin or other antiplatelets, and no smoking. And in addition to the high level of medical therapy optimization, which include all these criteria, it was 20% at the baseline, increased to 41 during the last follow-up visit. And we can see that the LDL below 70, it was 32% only of patients have LDL below 70 at the baseline, which doubled after the follow-up to 60% who achieved LDL less than 70%. So optimal medical treatment is important. And if we can see that the baseline LDL level was 83 milligram per deciliter, at the last visit it dropped to 65 milligram per deciliter. So if we compare the use of medications, beta blocker, there was no difference between both arms. Calcium channel blocker was used more in the conservative strategy compared to the invasive strategy. Other anti-angina medications were commonly used with the conservative strategy, and DAPT therapy, of course, was used more in the invasive strategy compared to conservative strategy. Cardiac catheterization was performed in 96% in the invasive strategy. In the conservative strategy, 28% crossed to the invasive arm. Why? Because they have suspected or confirmed acute event in 13%, optimal medical treatment failure in 3.9%, non-adherence for medications in 8%. Revascularization was performed in 80% of patients and 23% in conservative strategy. The mode of revascularization, either PCI, which was performed in 74% of patients, successful stent deployed in 93%, DES in 98%. Bypass surgery was performed in around 26%, arterial grafts in 93%, terminal memory in 92%. Why 80% only of those patients were subjected to revascularization? Because 20% of patients had no significant disease in coronary angiography, or they had an extensive disease which is unsuitable for any mode of revascularization. If we look for the primary outcome, interestingly, we can see there was no statistically significant difference between both arms, conservative versus invasive strategy. However, the two curves started to separate within the first year after 6 months in favor of the conservative strategy, because a high incidence of peri-procedural MI with the invasive strategy. And after 4 years, the curves separated in favor of the invasive strategy because the high incidence of spontaneous myocardial infarction with the conservative strategy. So there is an early benefit in favor of conservative arm and late benefit in favor of invasive strategy. And the same was documented regarding the major secondary endpoint, cardiovascular death or myocardial infarction, earlier benefit in favor of conservative strategy, and after 4 years, it was in favor of the invasive strategy. The p-value was not significant. So PCI did not reduce mortality or myocardial infarction compared with the conservative strategy. The net clinical benefit the same. And if we look for cardiovascular death, it was not statistically significant. So PCI in patients with a stable ischemic heart disease did not reduce cardiovascular death. And all-cause mortality the same. The probability of at least 10% relative risk reduction of the invasive strategy on all-cause mortality is less than 10%. So this was not statistically significant. So PCI in patients with stable ischemic heart disease did not reduce all-cause mortality. Myocardial infarction, we mentioned that earlier benefit for conservative strategy because peri-procedural MI was high, spontaneous MI after 4 years was high for patients with conservative strategy. Procedural MI again after PCI or after cappage was high after 6 months, and after 4 years, spontaneous myocardial infarction was high in patients who were subjected to conservative strategy. Hospitalization for unstable angina was significant with conservative strategy compared with the invasive strategy. Hospitalization for heart failure was significantly more with patients subjected to the invasive strategy compared with conservative arm. Resuscitated cardiac arrest or stroke was not statistically significant. Interestingly, the primary endpoint and pre-specified subgroup analysis, there was no heterogeneity of treatment effect regarding the core lab ischemia eligibility, regarding the high degree of baseline medical treatment optimization, or coronary artery disease severity based on 50% stenosis, or proximal LED or not, or degree of baseline ischemia, whether moderate, severe, or mild ischemia. There was no impact for these variables on the outcome when comparing conservative strategy with invasive strategy. Again, there was no heterogeneity of treatment effect based on any characteristics included age, gender, ethnicity, race, stress test, stress imaging, moderate or severe ischemia, LED or not, prior PCI, prior MI, or ejection fraction. What about quality of life, which is an important endpoint in patients with stable ischemic heart disease? Patients with stable coronary heart disease and moderate to severe ischemia had significant improvement in angina control and quality of life with an invasive strategy if they had angina daily, weekly, or monthly. And in patients who don't have angina, invasive strategy led to minimal symptom or quality of life benefits as compared with conservative strategy. What are the limitations of this landmark trial? It's unblinded trial, no sham procedure. Based on the exclusion criteria, the trial results don't apply to patients with acute coronary syndrome within 2 months, highly symptomatic patients, patients with left main disease, ejection fraction less than 35%, and the trial findings may not be generalizable to centers with high procedural complication rates. Completeness of revascularization has not yet been assessed, and women were enrolled in the trial but more often excluded from randomization compared to men due to less ischemia and more non-obstructive coronary artery disease. So the summary of ischemia trial. The curves cross for the primary endpoint and the major secondary endpoints at approximately 2 years from randomization, 2 in 100 high estimated rate with invasive strategy at 6 months, 2 in 100 lower estimated rate with invasive strategy at 4 years. Procedural MI were increased with an invasive strategy. Spontaneous MI were reduced with an invasive strategy. Low all-cause mortality in both groups despite high-risk clinical characteristics, high-risk ischemia, and extensive CED. No heterogeneity of treatment effect included by type of stress test, severity of ischemia, or extent of coronary artery disease, and the very low rates of procedure-related stroke and death. Ischemia is the largest trial of an invasive versus conservative strategy for patients with stable ischemic heart disease. Overall, an initial invasive strategy as compared with an initial conservative strategy did not demonstrate a reduced risk over a median of 3.3 years for primary endpoint, cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, resuscitated cardiac arrest, major secondary endpoints, cardiovascular death or myocardial infarction, and no significant effect on all-cause mortality. Quality of life improved in patients who were subjected to the invasive strategy if they have frequent angina daily, weekly, or monthly, but no impact on quality of life if the patient has no angina. So how to interpret the ischemia trial? Support for initial conservative approach when provided that there is strict adherence to guideline-directed medical therapy, optimal medical treatment, patients with stable ischemic heart disease who fit the profile of those in ischemia and don't have unacceptable levels of angina can be treated with an initial conservative strategy. However, the support for the initial invasive approach, an invasive strategy which more effectively relieves symptoms of angina, especially in patients with frequent episodes, is a reasonable approach at any point in time for symptom relief. So shared decision making between the patient and the physician is important to discuss the advantages and disadvantages of conservative strategy versus invasive strategy. It was a great pleasure and honor to be part of this landmark trial. Cardiology department at Cairo University have been included in the ischemia trial. So I'd like to thank all ischemia group from the cardiology department at Cairo University. Thank you for your attention.